Hello everyone, and welcome to my presentation. Today I'm going to talk about my progress over the past 9 months of my title of the PhD being Advances in Orthodontic Acceleration and Retention. My name is Adél Pintér, and I'm a fifth-year dental student as well as a first-year DMD PhD student here at the CTM. My supervisors are Gábor Gerber and Gábor Varga, and my SMS is Alex Schulte-Venning. I started this PhD with a vision to transform orthodontics into a treatment option that's seamless and has lifelong results. My mission is to identify the safest and most effective acceleration techniques of orthodontic tooth movement and retention. So for this purpose, I have 2 specific goals. The first one, investigating a surgical technique to accelerate tooth movement, and the second one is concerned with the use of fixed retainers of different manufacturing methods. So let me now start with my first project, in which I investigate the effectiveness and safety of micro-osteoperforations in accelerated orthodontics. But why accelerate orthodontics in the first place? So 200 million people worldwide require orthodontic treatment every year. As many of you may have undergone this process yourselves, you might remember the lengthy treatment times, which on average take 24 months. This causes 1 in 5 patients choosing to discontinue their treatment, and also poses several biological risks, such as the development of white spot lesions and the development of gingivitis, which affects almost all patients who are undergoing orthodontics. So this is where micro-osteoperforations come in. These are a surgical procedure whereby small perforations are made in the alveolar bone to stimulate bone remodeling and accelerate tooth movement. So our aim is to explore the effectiveness and safety of MOPs at accelerating tooth movement. Therefore, we ask ourselves the clinical question whether these MOPs significantly increase the rate of orthodontic tooth movement and whether they are safe for clinical use. Thereby, we are comparing patients who are undergoing orthodontic treatment receiving micro-osteoperforations to those who have not received these. We are looking at the outcomes, the primary one being the rate of orthodontic tooth movement in millimeters per unit time, and root resorption to include safety outcome as well. Down below, you can see a couple of other outcomes listed, which we are going to investigate depending on the availability in the literature. So we hypothesize that MOPs significantly increase the rate of tooth movement and reduce the rate of complications. Let's now look at a couple of my results, and we are receiving more as we speak. So the first one is overall treatment duration. For this one, we used a ratio of means to understand by what factor MOPs might potentially reduce treatment times. So in this one, we included 8 randomized controlled trials with around 100 patients. As you can see, our ratio of means in this case was 0.78, which means that patients undergoing orthodontics who have received micro-osteoperforations completed their treatment 22% faster than those who were in the control groups. This could mean that we can actually accelerate tooth movement and provide a significant benefit in patients' quality of life during the treatment. For my second plot, which indicates the anchorage loss, this is one of our safety outcomes. And for this one, you have to imagine the clinical scenario of extracting first premolar teeth for the purposes of space creation. And we are trying to now retract anterior teeth to this gap. So thereby, we are just trying to move teeth that were in a more forward position back, but we are trying to avoid the movement of posterior teeth forward. So this outcome is very relevant in terms of the efficiency of our treatment and is a major concern in the conventional approach to orthodontics. So what we saw in this one was a mean difference of -0.12, which you can see is way below the clinical threshold of acceptable anchorage loss, which lies between 1 and 3 millimeters in conventional treatment. So this is a statistically significant result, however, it has a limited clinical relevance. And so here's the progress of my first project, and we are currently in the phase of receiving tables and running new analyses. So let me now come to my second project, in which I investigate the stability and the survival of fixed retainers of different manufacturing methods. So why use fixed retainers in the first place? In this picture, you can see some teeth where a fixed retainer has become visible. This retainer was placed after the teeth had been aligned, so they would not have been visible from the buccal aspect, as you can see now. This means, what we can see in this picture, that the teeth have moved, and therefore that our retention was ineffective. Over 70 to 90% of patients experience some sort of relapse, which expresses the need to investigate this topic. So what we use conventionally are multi-stranded stainless steel wires to stabilize teeth post-treatment. However, these face a number of complications such as bond failure, unwanted tooth movement, caries, and gingivitis via the plaque retention. However, with the rise of digital technologies, now there's CAD/CAM options available, which allow for the digital design of these appliances, offering superior aesthetics, a custom fit, and better stability. Therefore, we ask ourselves the clinical question whether CAD/CAM manufactured fixed retainers offer better stability than conventionally manufactured multi-stranded stainless steel ones. Thereby, we are comparing patients who are undergoing orthodontic treatment, receiving CAD/CAM fixed retainers compared to conventional ones. We are looking at the stability and the survival of these fixed retainers as our outcomes. If our hypothesis is true and CAD/CAM fixed retainers are actually superior to conventional multi-stranded stainless steel ones, we can improve the long-term stability of aligned teeth and reduce the biological risks associated with repeated treatment, and thereby improve patients' quality of life. So as I conclude, our projects, the first one is planned to be terminated by July this year, and the second one by March next year. And let me now finish my presentation with the words of Robert A. Heinlein: everything is theoretically impossible until it's done. Thank you for your kind attention.
Thank you for your nice presentation. The discussion is open.
Okay, so thank you and congratulations on your presentation and also on your impressive results. I would like to ask a question regarding your first project and its results. So about the plot about treatment time, some of the results or the studies had a much higher effect on the result. Do you know why it is?
Yes, so that's a very good point. As you can see in the plot, there's quite a bit of a divide between the first 4 studies and the second 4. So we did investigate the reason for this. And so the first 4 studies, so first we have to say that all of these studies investigate different types of orthodontic treatments. And this was our aim, to just understand whether these perforations are effective in any type of treatment and whether they overall improve treatment times. So the first 4 studies, they investigated patients who needed decrowding. So actually, no, sorry. Yes, they did. So the first 4 investigated crowding. So these were done in the mandibular jaw. And so this means that the teeth needed uprighting and possibly rotations, but not bodily movement. However, the second 4 group of studies, they investigated canine retraction. So in this case, premolars were extracted and then the canines were moved back. So that's what explains the big difference between these studies, the fact that the nature of the movement was very different.
Thanks. And do you plan to make subgroups based on this?
Yes, definitely. There will be subgroups based on the type of intervention, as well as the jaw that was involved due to the differences in bone structure and also the type of movement that was needed. But this was just a way to get an overview of what we should be looking into more precisely.
Thank you.
Thank you.
Next question. Hi. Thank you for your presentation. For your second topic, you mentioned that there's this CAD/CAM printed version. And so what is this made of? Is this like plastic? Because isn't there a thing that like bacteria adhere better to plastic than to metal?
Okay, yeah, so that's a very good point. Thank you for your question. Basically, there are a really wide range of materials we can use for this, down to titanium, and we can also use special polymers such as PEEK, which is a biocompatible polymer, and it actually shows better properties in the plaque retention, so it retains less bacteria compared to, for example, that multi-stranded one, which because of the multiple strands is a great plaque trap. So it really depends on the type of material that you're using, but the main ones are PEEK and titanium at the moment.
Thank you.
Nice.
Thank you for your nice presentation. My question is related to your first project. What do you know about that MOPs lower the risk for relapse also?
Okay, thank you for your question. So MOPs themselves, they are not suitable to influence anything that's post the actual active orthodontic treatment, so they don't do anything after treatment. However, there are quite a few surgical methods which are combined with bone grafting procedures, which can then lead to reduced relapse rates because of the added bone volume after treatment. So that's a really good point, but the micro-osteoperforations themselves, they cannot do that.
Thank you.
It was a very nice presentation, first of all. For your first project, I have a question. So, since micro-osteoperforation is some sort of minor surgery, and one of your outcomes are pain, I was curious how you're going to assess pain, because surgery can be painful. Is it pain after surgery, or is it pain during orthodontic treatment, and how long is the approximate duration if it's after the surgery?
Thank you for your question. Actually, many of patients were wondering the same thing. So basically, obviously, a surgical insult is always going to be painful. However, this is carried out in local anesthesia. However, after it wears off, a lot of the studies investigated pain levels post-treatment, and the main follow-up times for these were the same day, 3 days, 4 days, and then 7 days. So this indicates that the pain doesn't last for very long. So it seems to be quite tolerable.